to the UK Dementia and Palliative Care Conference 2025 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. Across these episodes, we'll be sharing expert insights, real-life experiences, and innovative approaches to improving care. Thanks for tuning in. Let's get started. The keynote address on palliative care for people with dementia and what we can learn from big data to support better care decisions. Presented by Professor Liz Sampson, Professor of Liaison Psychiatry at the Academic Centre for Healthy Ageing, part of Barts Health NHS Trust and Queen Mary University of London.
Thank you, and I'd just like to thank the team from Rowcroft for inviting me to this beautiful location to come and speak today. So I'm Liz Sampson. I'm a liaison psychiatrist, so I work very much at the very messy but interesting interface of physical and mental health. And I also have a specialism in older people, particularly dementia and delirium, and people with cognitive disorders. And I work in East London, so this is beautiful to be here, a very different location. I remember the first meeting I had with the Rowcroft team, and they gave me quite a challenging but good brief, which was they wanted to hear about some work we'd done with data, but they also wanted us to really present how collecting lots of data can be very helpful in terms of developing new interventions and new ways of caring for people. So I'm going to start off by presenting some graphs. You don't have to take in all the detail and all the data. I just want to kind of illustrate how we use data in research to build up a picture of what's going on. We're going to talk about what happens then across populations, what happens in hospitals, what happens to individual patients and their carers and people with dementia and staff, and then really think about the families and what we can do to help improve care. And what I also want to talk about is how we've come full circle with our data in terms of then, I was struck by how Mark mentioned about making connections. And we've then taken lots of population level data, learnt about the population, found new ways to improve care, but then we need to get that information back to people, real people. So talk about some really fun and interesting public engagement work we've done around this. So the data that I'm presenting today comes from a research programme called EMBED-Care, Empowering Better End-of-Life Dementia Care. And it really wouldn't have been possible without a huge team effort. So at the time I was working at University College London, and we joined up with a team from Cicely Saunders Institute, a very famous institute of palliative care. So the top two photos are taken in 2017 when we locked ourselves in a darkened room with a carer panel, and carers were involved and people with early dementia were involved in developing the grant from the start. And that was our messy whiteboard where we put together this huge £5 million grant application. And then the bottom picture was taken at Christmas when we presented our final policy report at the House of Lords. And I really have to thank all of my team. I'll mention them as we go through, but particularly Professor Catherine Evans from Cicely Saunders Institute. Some of you may know her and her work. She's in the yellow jumper at the end, and she was my co-principal investigator, and we really couldn't have produced this huge amount of work without working together across the two institutions. So I just want to sort of take you through the anatomy of one of these really big research projects, because they can seem quite abstract and you see lots of papers being churned out at the end. But what we do is we use different building blocks. So the WS stands for work stream. So our first work stream was looking at policy and guideline reviews. I'm not going to talk so much today. So pulling together the existing evidence. And that was led by Catherine Evans. Our second work stream was led by Professor Catherine Sleeman, and this is about looking at large data, and I'll talk a lot more about that in this presentation. But we then needed to drill down into more detail, so we did a cohort study where we follow up individual patients and their carers and their experiences. Then what we do is we kind of mix all the data together in a data synthesis, and we use that to co-design integrated interventions that might improve care for people. And then finally, we test the interventions that we develop in the final work stream 6. This all looks very neat and organised, but then obviously COVID came along and we had to really transfer a lot of our research online, but we had fantastic support from our PPIE and our participant groups. Running through all the whole of the programme was patient and public involvement, embedded all the way through, and also engagement. And as researchers, we weren't particularly good at the time with public engagement, so transmitting our findings out there, and we've learned a huge amount from that process. So the aims of this huge Empowering Better End-of-Life Dementia Care research programme was to try and leverage a step change in palliative dementia care, create new networks for knowledge, engagement and research, to pilot new models of care that empowered people to really think about the symptoms that they were experiencing and address those symptoms across a range of settings, and then to deliver that in real-world situations. But we also wanted to build capacity in dementia research. So we've had 6 PhD students who've come through our programme. We've had 4 babies, not me, other people. And what's been fantastic about that is all of those younger researchers have now come back from maternity leave. They've moved on with their careers, and we've supported them through that. And that's really, really important in terms of making sure we've got the next generation of people coming through. And as I mentioned, delivering public engagement and embedding patient and public involvement all the way through the programme. So now some charts and data, but just to help build up a picture, this isn't our data, this is just data from Alzheimer's Research UK. Many of you may have seen these charts. I'd really recommend this website because it produces these beautiful graphs that you can download and use to make your case, whether that's with commissioners or service providers. And so you can see that this thick orange line, which is dementia and Alzheimer's disease, is now becoming the leading cause of death in the UK. And you all know that. But this data and this kind of graphic is very important when we're trying to build our case. What we thought was, rather than instantly reaching for the healthcare data, we'd asked the general public what they thought. And we wanted to survey public attitudes about dementia and end-of-life care. And what we did was we did a huge public survey with YouGov, which as researchers we don't normally do, but we wanted to try new methods. So we asked people of varying ages which they thought was the leading cause of death in England. And as you can see, not many people picked Alzheimer's disease. Interestingly, more people in the 18 to 24 age group correctly picked Alzheimer's disease, but still heart disease and cancer were the most popular pick. So this is a typical graph that we might show as an academic, but it's busy and there's lots in there. So what we tried to do was convert this large data set into more meaningful materials where we could communicate our message. So we worked with a graphic designer to produce infographics. We've had them printed out and we use them a lot in our public engagement work and education. So going through YouGov was brilliant because they were able to sample over 2,000 adults. And if we'd have done that as a research project, it would have been a very messy and very difficult project to do. But they're able just to make a population sample which is representative of the UK. So 9 in 10 people didn't know that dementia was the leading cause of death in the UK. Only 7% understood that the number of people with dementia is going to double. Only 17% of the public were aware of the fact that most of the cost is borne by families. Only half of people really understood that palliative care could improve quality of life. And only 1 in 4 people believed palliative care was only for people who were imminently dying. So this is an illustration, I guess, of how we take big population opinions and views and start to distill where the public knowledge is at. And that's really important because, as Mark mentioned, if you want to provide services, you need to convince people, and commissioners and planning departments are all the public. So it's important that we understand where they are. There's other ways that we can look at data. This is quite a potentially messy graph, but I guess because of my research interests and also because of my clinical work, we were beginning to see patterns of people with dementia coming to accident and emergency departments. And this is a really elegant study done by my colleague, Catherine Sleeman. If you move along this way, it's just showing you that you've got a greater risk of coming to emergency department. So this uses data from South London, over 20,000 people with dementia. So we've gone from the general population to now specifically looking at people with dementia. And what you can see is that there are certain groups of people who are more likely to end up in an emergency department when they have dementia. So men, people who aren't white background, people with vascular dementia, people with depression, and also there's a time trend here that appears to be increasing as well. So the year that you died drove that. So this starts to give us some clues really about perhaps why people are heading to the emergency department. And also, it's not all negative because we begin to understand potentially protective factors. So we hear a lot of bad news about care homes, but being a care home resident actually protects you and means you're less likely to go to the emergency department, which is quite different from some of the current government rhetoric that we see. This is some work done by one of the PhD students on our programme. So we thought, well, people with dementia are coming to emergency departments. A lot of them are being admitted to hospital. What can we learn about this group? So this is quite a complicated graph, and it even took me a while to get my head around it. But what it's showing is that the longer you're diagnosed with dementia, the less likely you are to have a hospital admission nearing death. So there's something about having an early diagnosis. Perhaps you have a more chronic, milder form of the disease. Perhaps you have fewer comorbidities. Perhaps having an earlier diagnosis gives you time to get the care in that you need. But what was quite striking is that those people who are diagnosed late, so very near to death, are much more likely to have an acute hospital admission in the last year of life. And many of those people may actually only receive a diagnosis when they go into hospital at the last year of life. But more strikingly, we found that on average, the people with dementia in this cohort, so again, a cohort of 20,000 people, spent a month of the last year of life in hospital. And that's probably due to challenges with symptom management, but also finding the right places for them to live and finding places that can help manage the complexity of symptoms that they have. So another part of the picture is costs, and this is really important to understand. So the costs of healthcare for people with dementia towards the end of life are largely driven by hospitalisation. But I really want to emphasise this, the cost of healthcare, because there's a very simplistic view that if we keep people out of the acute hospital sector, we save money. But of course we don't, because that cost then moves on to other sectors. So it moves on to hospices or care homes. So what you can see is that if you have a hospital transition, most of your costs are borne by the residential care sector or informal care costs, and then home care costs. Not much palliative care, but slightly more palliative care costs than if you go into hospital. So this is a really important message to get out, because I think one of the things that's frustrated us over the years is the constant preoccupation with reducing admissions to hospital, with little nuanced thought about, well, where do we provide better care then, and where does the cost of that come from? And finally, I promise we're getting to the end of the graph, but this is really important as well. We thought it was important to estimate the future need for palliative care for people with dementia. So these are various estimates. So we start in 2020, and then we look at potential relative increases in dementia incidence. So if there's no change in the numbers of people coming through the population with dementia, we will follow the green line. So these will be the number of people dying with dementia in the future. So currently it's 274,000 a year, and if the incidence rate of dementia stays the same, it will go up to 521. So this is why we need to get our public health measures in terms of reducing dementia. If there's a 2.8% increase in the numbers of people with dementia in our population, which there could be, given lifestyles, people living longer, then we're going to be looking at double, triple the number of people dying with dementia in the future. So data is power, and when you're planning your services, it's good to be forewarned. So that's why the new provision that Mark was talking about is so exciting, because it's so necessary. And finally, the last study. This study looks at large groups of people, so again, nearly 6,000 people with dementia. And what this study showed was that if you identify palliative care need in primary care towards the end of life, in the last 90 days of life, you have lower risk of multiple hospital admissions. So just assessing and identifying palliative care need lowers the risk of hospital admissions. And once you identify that unmet need, you have more contact with the services that you need. So this was really interesting because this begins to hint about the power of just identifying need and assessing need and comprehensive assessment. So this very common idea that we have certainly in liaison psychiatry, in mental health and in palliative care and in comprehensive geriatric assessment, that assessment of need is an intervention in itself. And that's very important moving forward. We've also done some other studies which I won't present today, but we did much more detailed studies where we actually recruited people with dementia and their carers and followed them up every month, because data doesn't give us everything. It doesn't give us that really nuanced data. Are they in pain? How many times have they been in hospital? Are they having behavioural problems? Are they very distressed at home? Are they up all night? How much stress are carers under? Are carers becoming depressed? So in these projects, we followed up people with dementia. We also worked with the National Prion Unit to specifically do the first study of end-of-life care needs in people with prion dementia, so a very rapidly progressive dementia. And we also did a study on people with young-onset dementia, frontotemporal lobar degeneration as well. And those results will be coming out over the next few months. So we then had to think, we have all this data and we have all this information, how do we develop an intervention that might start to improve care, that's accessible, that can be delivered by the multidisciplinary team? We already had the IPOSDEM, and many of you may have come across this. This is the Integrated Palliative Care Outcomes Scale, developed by Claire Ellis-Smith at King's College. And the IPOSDEM is a system checklist, and it's specifically designed for people with more severe dementia, and you just go through with the carer and you identify which symptoms the person's been experiencing. And then it also helps you prioritise, because one of the things with dementia is that people become overwhelmed by the complexity. And the IPOSDEM helps you identify what are the top 3 symptoms that we want to address here. What is most important to the person with dementia? What is most important to the carer? So we already had a really good tool that we thought would help identify and assess the symptoms and the problems that people with dementia and their carers have. And it's holistic as well. It doesn't just look at physical symptoms, it looks at distress and social and psychological well-being. This is some work that Claire Ellis-Smith had done. So what she showed is that the outer line is the initial assessment, and then merely by doing that assessment, you go back and the symptoms appear to improve. Now, that could just be natural regression, but when she did further studies, she found that just assessing people and documenting their needs actually moved someone, say, from here to a lower symptom burden here. So this was some good evidence, we thought, that just having a detailed assessment was really helpful. However, what's really important is that after we assess someone, we know what to do. And so we started to co-design a framework where we wanted to really think about how we assess someone. How do we then think about the next step? What do we do next? So this is one of our co-design groups. This is at the University of Bradford. So we worked with people with dementia, current and former carers, and practitioners across a range of settings and specialities. And we designed a framework for our assessment to sit within, a clinical framework, which I'll talk more about. We then tested it with professionals and carers of people with dementia, and we explored what sort of things would stop us using this in practice. And we very much kept redesigning, thinking about implementation in real life. So another colleague that we've worked with very closely is my colleague, Professor Nathan Davis. And Nathan has done some really interesting work around heuristics. And heuristics are really just simple rules of thumb. They're the way that lots of clinicians think. If you go and see someone at home and they are presenting with a particular problem, what a lot of you will find is that you're mentally working through a checklist, often unconsciously, without even realising that you're doing it. So heuristics, or rules of thumb, are a way of us making that implicit specialist knowledge that we all hold explicit. It's a way of putting on paper those clinical thinking processes in the neatest, most simple, parsimonious, common sense way. So this is just a heuristic looking at ways we can think about causes of pain and then how we assess and manage pain. And we worked with a designer very closely and with a co-design group to say, right, you've done your IPOS-DEM, you've found out that someone's in pain. How do we then act upon that? And these are all different design prototypes. This one is kind of here is quite attractive, but it's a bit messy, and if you're busy and you're working in a care home, that's not so great. This one has got a lot of detail in. This one is a bit simpler. So it's all about kind of creating the hive mind knowledge and then organising it in a really simple way to give people the confidence to think, well, actually, I can work through some rules of thumb here that might help me address the symptom of pain. So we then moved on to a larger programme of co-design work, again using all of our data. And what we decided was we have the IPOS-DEM assessment tool, we have the generation of priorities for the person with dementia and their carer. That's really important because what we think as healthcare and social care professionals might be the number one priority might not be the number one priority for the person with dementia or their carer. And then we designed simple rules of thumb for sleep problems, lack of activity, pain. Basically, every symptom in this checklist has a rule of thumb attached to it. So you then build up a more holistic kind of intervention. So we have our holistic IPOS-DEM tool, we have our best practice and evidence-based management with our decision support tools, shared decision-making, really, really important, as I said, sitting down with people, what's important to you, priority setting here. And all of this was delivered through an app, but it can be delivered on paper depending on the context that you're working in. So, just to finish here, this has now been feasibility tested. It's been tested in care homes in the South Coast. It's been tested in community settings with people living at home in London on the South Coast. And also we have a team up in Derby using it as well. And I can't talk about the results because we're currently crunching all of the data on that project. But hopefully they will be out within the next year or so. So this is great. We've done what we said to our funders we would do. We've done lots of data research. We've produced probably 40-odd academic papers. But those academic papers are just going to sit in a silo somewhere unless we get out there. So we thought, let's really push ourselves out of our comfort zone and mobilise this knowledge back into the population. And this was one of the most extraordinary learning experiences of my career, because we're not trained as clinicians or researchers to do high-quality public engagement. So we worked with a public engagement specialist. We costed them into our grant to really help us do this work properly. And what we realised that it was a very commercial way of thinking. So we had Emily Scott-Deering, who was an amazing public engagement specialist. She'd worked on the cheering exhibition at Bletchley Park. She had won awards for the welcome galleries, the medical galleries at the Science Museum. And what we realised is that in buying Emily's time, we were buying her address book and her years of contacts. So she got us an initial public engagement event at Science Museum Lates. And for those who haven't come across these, this is where the Science Museum in London is opened up one night a month, specifically to attract an 18 to 35-year-old audience. They have DJs, there are cocktails, they have themed evenings. Sometimes it's space. We were invited to go to the Science Museum late, I think it was July 23, which was about NHS and healthcare. And we had to think of a whole range of engagement activities for this group. And we thought, well, if we can engage 18 to 35-year-olds in this issue, we know we're onto something. So and this is why, it was really, really important, because we had a number of young research assistants. You know, our team was about 30. We had a number of young research assistants, not old fuddy-duddies like me, who came up with really creative ideas about how we engage with this group, because they were the target audience. So we had a beautiful wishing tree where people could write their end-of-life wishes. They made a card game. So we had lots of qualitative research about what carers wanted and what people with dementia wanted. And what was quite interesting is that they didn't match up a lot of the time. So we made a really interesting card game for people to play. It was called Knowing Me, Knowing You, which they didn't get the Alan Partridge reference. I did. I just left it. But anyway, they developed this wonderful game called Knowing Me, Knowing You, where people sat down and you had to guess what people would want at different stages of their life. When you got older, what sort of care you wanted, what music you wanted at your funeral. And that was great. We had the cards out and we did a quiz around these cards. So that's the iPad that you can see at the end. And people got prizes when they answered the quiz properly. Barbie had just come out, and for those of you who've seen Barbie was very actually existential, and Barbie has that moment when she says, "Hey guys, do you think about dying?" So we did publicity materials around that, and then we all wore orange T-shirts and tried to look youthful. And it was incredible, and over 300 young people came and talked to us about dementia. And obviously they're a self-selected population. There was lots of other health-related activity going on. Most of them had a story about an auntie, uncle, grandma. Some of them sadly had stories about mum, dad, other closer relatives. But the engagement was incredible and very encouraging. So we thought, well, what next? So we then had the opportunity to work with Science Gallery London, which is on the South Bank, just near London Bridge Station and the Shard. And we decided that we liked the idea of really thinking about carers and their experiences and the journey that they went through. So we worked with a photographer called Ali Crew, and she took some beautiful portraits of carers, and this is Tia, one of our carers. And Tia had decided that at the point where her grandmother was supposed to be going into a care home, she wasn't happy with that, and she gave up her studies temporarily, and she looked after her grandmother at home until she died. So we found some amazing carer stories. We also worked with Keiko, who was a carer for her husband, and Fran, who cared for her mum. So this is Keiko, and this is Fran, and this is Tia. And then we worked with a graphic artist, Ian Macmillan, and the whole idea was about telling these people's story, but also telling the story of research. So Catherine and I were immortalised in cartoon form, and this is all of our leadership of our research team. So Claire, Catherine Sleeman, Nathan Davis, all drawn out. And this was a big panel that told the story of the research and linked it to the personal stories of these carers. And then the final thing we did was our graphic artist, Ian, who was a GP actually as well. So he really understood, spent time with the carers. And so this is Tia's story here about looking after her grandmother. And it was a huge panel telling, here we are, I decided to become Nan's full-time carer. And then she tells the story. I was working as a trainee restaurant manager, but she decided to become Grandma's full-time carer. We wanted to bring these stories out into the open and tell the experiences that they'd had. This is Tia's mum. This is really moving. Actually, this is Tia's mum when she saw the strip, and her pride at, what her granddaughter had done and the way the family had worked with them was immense. As part of that exhibition, we also had this wall, which would be filled up. The exhibition ran for about 6 weeks, and every week or so they would paint over this and people would put their wishes in it. We took a photograph every time, so we've got all that really, really rich material about what will be important to me at the end of my life. A really good way of getting people to engage and think about things in a way that's non-threatening. And then we had a zone where people could learn more about palliative care. And we also had this. And this is a manifesto written by carers with the poet Louise Wallstein, MBE, who's an award-winning poet. And she created this poem or this manifesto with our carers. And I don't have time to read it, I don't think, but I've got lots of the cards here and I'll leave these around. And it starts, we are the carers, in the unseen chaos of twilight and the dawn, the dedicated, hidden, unheard activists, motivated by love, unpaid, isolated, invisible. And then they go on to really speak their manifesto. So what we did was we turned this is actually a postcard, and we printed hundreds of these, and it was addressed to the House of Commons, and people could then send it to their MP. So this is really important because, as I said at the beginning, we're looking at huge population health issues, but the only way you can change policy sometimes is by lobbying individual MPs. So you have to kind of go full circle round. So anyway, we thought we were really clever and brilliant producing all of these postcards, and hundreds got sent off to the Houses of Parliament. But if I said that the exhibition opened at the end of May last year, you'll know what happened. And then they called an election. And I suspect that lots of these sat on the desks. But it was a really interesting idea. and they're still around and about in the community and being sent in. But I think that's just an illustration, really, of how when you're working in research and you're trying to affect policy, things happen above your head and at a high level that you can't really control. But we ended up with this beautiful, very, very inspiring manifesto. So finally, where are we now with all of this work? Well, we thought, this is great. We've had, about 3,000, 4,000 people through this exhibition. This is exposing a whole group to perhaps the world of dementia, palliative care that they wouldn't have previously seen. And then one of the things that our public engagement specialists encouraged us to do was go large. So we went large and we moved it into London Bridge Station over the autumn. And we had all of these cubes around London Bridge Station with the graphics and the artwork on. So this is one of the cubes that we had. And this was incredible because London Bridge Station has a footfall of about 120,000 people a day. And obviously not all of them would have seen this, but it was a lovely way of really putting the story out there, because I think it is a hidden world. And until you experience it yourself, I looked after my dad. He had vascular dementia about 10 years ago, and he sadly died from that. But until you experience that yourself, you have no idea what this is like. And it is quite hidden away. We have sort of dedicated advocates in the room, but we wanted to really use what we'd learned and the beautiful things that we'd produced to get it into a public space. So that's how things ended, really. So hopefully I've kind of really whizzed through, but taken the whole story and shown how we used big data. We then looked in more detail at people's experiences and have tested new ways to improve care. My co-investigator, Catherine Evans, working alongside Emma Warburson, who some of you may know, were recently funded for the Empower Network, which is a whole new network which really exists to promote dementia palliative care, and that's going to be ongoing. There's no website yet, but this is the announcement website. I'd like to finish by thanking all of our programme partners. You can see the numbers of people here who supported this huge piece of work, and also our funders, the Economic and Social Research Council and the National Institute of Health Research. It's a huge team effort, and I'm really delighted that Catherine and Emma will be taking this Empower Network, bringing together experts from all over the country, really, to use what we've learned, but also bring in partners and shared learning. So thank you very much for inviting me today. This is where I work. This is the Royal London Hospital. It's a behemoth, all 14 floors of it, all 900 beds. But East London has its own beauty, as you can see. And I think what's really exciting now is thinking that the next time I'm working in A&E and a frail older person comes in with dementia, we're beginning to have better systems and ways of looking after people. So thank you very much.
That's it for this episode of the UK Dementia and Palliative Care Conference 2025 podcast. A huge thank you to our sponsors, Majestic Holidays, Wallens, Amica Care, MC Hearing and Audley, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.